All right, let's dive right into this explainer. Today, we're unraveling a pretty fascinating medical whodunit centered right on the pituitary gland. When this incredibly delicate hormonal command center is compromised, the body just goes completely haywire. We're going to draw directly from the medical data on cellular masses to explore the subtle clues, the unbelievable biological power, and the remarkable interventions involved in treating them.
Now, I want you to think about this for a second. How could a tumor, one that is literally smaller than a pea, force you to go out and buy a larger pair of shoes? How could something so minuscule completely alter your skeletal structure as a fully grown adult? Well, this bizarre reality is exactly what we're going to unravel today. We're looking at the startling consequences of a breach in the body's hormonal headquarters, where the tiniest cellular rebellion can literally reshape your entire physical reality. To really grasp this, we've got to talk about scale. The normal height of the pituitary gland is just 6 to 8 millimeters. That's it. It sits tucked away in the sella turcica, which is this tight little bony vault right at the base of the skull. It is absolutely astonishing that a structure this minuscule regulates our entire biological system. We're talking everything from our growth and metabolism to our response to stress and our ability to reproduce. And this creates what is basically a microscopic real estate crisis, what we call the mass effect. Because the pituitary is completely boxed into that tight bony vault, any tumor growth runs out of room fast. So the physical direction that a tumor grows purely dictates what neighboring structure gets squished, creating a highly predictable map of symptoms. If it grows upward or superiorly, it hits the optic chiasm. If it grows laterally, it invades the cavernous sinus, which affects your eye movement. It's a classic real estate problem, you know? Location is quite literally everything.
And man, these anatomical invasions lead to some wild, highly specific symptoms. A mass growing upward causes bitemporal hemenopsia, meaning the patient literally loses their outer peripheral vision. It's an extreme tunnel vision effect. If a mass grows down into the sphenoid sinus, it can cause cerebrospinal fluid to leak right out of the nose. Crazy, right? And if a mass, like a hypothalamic hamartoma, develops, it can even cause precocious puberty and gelastic or laughing seizures. The symptoms are just as varied as the complex structures surrounding the gland itself.
So, who are the usual suspects here? Well, we are generally talking about benign pituitary adenomas. Prolactinomas take the lion's share, making up a massive 50% of these invading adenomas. Next up are the non-functioning adenomas at 30%, and then that's followed by tumors secreting growth hormone, ACTH, and very rarely TSH. Now, before we dig into the specific tumors, let's establish a crucial threshold. A macroadenoma is a pituitary tumor measuring 10 millimeters or greater. Remember, the healthy gland itself is only 6 to 8 millimeters, so a macroadenoma is basically a tumor that has entirely overgrown its home. These larger tumors are the primary culprits behind that mass effect we just talked about, leading to visual loss and hypopituitarism by literally crushing the normal healthy gland tissue. Okay, this brings us to one of the most high-yield diagnostic traps in all of endocrinology. A large mass causing a mild prolactin bump is not necessarily a true prolactinoma. See, the hypothalamus constantly sends dopamine down the pituitary stalk. It acts as an off switch to keep your prolactin levels low. But any large tumor can pinch that stalk, blocking the dopamine and causing a mild rise in prolactin, usually hovering between 30 and 100 nanograms per milliliter. We call this the stalk compression effect, and it is completely different from a tumor that is actively manufacturing prolactin itself. To prove you're looking at a true prolactinoma, we need to see this specific number, greater than 200 nanograms per milliliter. In endocrinology, the numbers tell the real story. If a patient's prolactin is over 200, you're looking at a true prolactin-secreting tumor, not just some random mass pinching the stalk. Making this distinction is absolutely vital because it completely flips the treatment plan, as we'll see in just a bit. So remember that mysterious shoe size increase we hooked you with at the beginning? That is a classic hallmark of acromegaly. It's a condition where a somatotrophic adenoma basically jams the master gland's growth hormone dial permanently into the on position. Because adult growth plates are already closed, the excess growth hormone causes the bones in the hands, the feet, and the face to steadily thicken over time. Patients often only realize something is wrong when their rings no longer fit or their shoe size mysteriously goes up. Now, another hormone dial that can get permanently jammed is ACTH, which leads to Cushing's disease, when an ACTH-secreting tumor just floods the body with excess cortisol. The systemic physical changes are dramatic, to say the least. Patients develop central obesity, a rounded moon face, and thin skin that easily bruises and tears into these striking purple striae. They also experience significant muscle weakness. It is a devastating condition that fundamentally alters a person's entire metabolic and psychiatric well-being. But here's the catch. Not all cortisol floods actually come from the pituitary. We have to compare the stealthy, gradual progression of a pituitary ACTH tumor against a massive hormonal flood from an ectopic source, like a rogue lung tumor secretly producing ACTH. Pituitary Cushing's is usually caused by a tiny microadenoma. It has a gradual onset of symptoms, and it still partially responds to a high-dose dexamethasone suppression test. Ectopic ECTH, on the other hand, it hits hard and fast, brings on severe symptoms like hypokalemia, and completely ignores any feedback suppression. We also can't forget the silent invaders. Up to 30% of these pituitary tumors are non-functioning adenomas. They don't pump out any excess hormones at all. They just quietly grow. And because they're hormonally silent, patients usually don't even notice them until they become massive macroadenomas. By the time they're actually discovered, it's often because the patient's vision is failing due to the tumor just crushing the optic chiasm. So, all of this builds a really clear 4-step medical detective process for evaluating any cellular mass. First up is the gold standard, an MRI of the pituitary with gadolinium to see the exact size and location. Second, you run a basic hormone panel to check for either hypersecretion or hormone loss. Third, formal visual field testing to check for any optic nerve compression. And finally, based on all those results, the care team determines the best eviction strategy. And speaking of eviction strategies, check out this incredible medical fact. Prolactinomas are totally unique among these tumors because they can often be dramatically shrunk using just medication. That means entirely avoiding brain surgery. Cabergoline is the first-line treatment here. It's a dopamine agonist, meaning it perfectly mimics that natural off switch we talked about earlier. It's highly effective at shrinking the tumor down and normalizing those hormone levels. But, what if the tumor doesn't respond to drugs, like with Cushing's, acromegaly, or one of those large non-functioning adenomas? Enter this absolute surgical marvel, transsphenoidal surgery. Neurosurgeons can actually evict the tumor by going right up through the nose and the sphenoid sinus, straight into that bony vault. It's a brilliant approach because it avoids having to open the skull or retract the brain itself, which makes recovery significantly faster for the patient. Of course, eviction is rarely without some collateral damage, right? The pituitary is a crowded, incredibly delicate neighborhood. Post-surgery, patients can experience diabetes insipidus, or DI, where the body loses its ability to concentrate urine, leading to massive water loss. Now, this is usually transient, but it ends up being permanent in about 10% of cases. There's also a 4% risk of a cerebrospinal fluid leak, and if the healthy gland is damaged during the process, hypopituitarism results. Interestingly, growth hormone is famously the very first hormone lost to this kind of injury or radiation. Now, here is a massive, high-yield diagnostic trap you absolutely have to watch out for. When evaluating a non-functioning adenoma, you might see mildly elevated FSH or LH on a lab test. But remember, elevated gonadotropins alone do not equal a gonadotroph adenoma. Interpreting this control room signals requires deep clinical context. Those mild elevations often don't cause clinical syndromes at all, so you really have to rely on the MRI and the presence of mass effect symptoms for your true diagnosis. Because the danger isn't just to the pituitary itself. If a mass grows even slightly upward and posterior into the hypothalamus, it can completely shatter the body's baseline wiring. Damage to the ventromedial nucleus causes extreme insatiable hunger and rapid obesity, while hitting the lateral hypothalamus causes severe anorexia. The anterior and posterior regions, well, they control your internal thermostat. A lesion there can literally strip away a patient's ability to maintain a normal body temperature. Finally, while almost all of these tumors are totally benign, we do need to briefly mention the rule breakers. Aggressive adenomas, notably silent corticotropes, just refuse to leave quietly. They exhibit rapid growth, high recurrence rates, and they have a really high K67 cellular proliferation marker. These stubborn invaders require the heaviest medical artillery we have. We're talking moving beyond just surgery and radiation to aggressive multimodal attacks, including chemotherapy drugs like temozolomide. We've covered the massive systemic ripples caused by just a few millimeters of misplaced tissue today. And honestly, it leaves us with a pretty profound realization. If our entire physical reality From the size of our shoes and the structure of our bones to our very appetite, our temperature, and our mood, is ultimately governed by a 6 millimeter cluster of cells in the dark center of our skull. Well, who is truly in the driver's seat? It's an incredible testament to the terrifying fragility, but also the awe-inspiring power of the human body's tiny control room. Thanks for exploring this explainer with me, and we'll catch you next time.